Welcome everybody to the Health and Government Operations Committee meeting this afternoon. We are letting in witnesses as we speak, but I just wanted to make sure everyone was welcome and knows that this meeting is being streamed on the Maryland General Assembly's YouTube channel. Committee members will be muted during the hearings. Following the presentation, please use your raise hand function if you want to ask a question, and we will make sure to unmute you. So wait for a second for your mute to be turned off. Keep in mind that even though we are meeting on Zoom, we are adhering to our usual committee rules. That means members will ask one question that will be brief, and the answer will be directed to one panelist. One question, one answer. If there's a really pertinent follow-up, we might allow for that follow-up. With that, the first hearing of the day is House Bill 21, Delegate Cullison. It is State Board for the Certification of Residential Child Care Program Professionals, Membership and Official Seat. Delegate Cullison.
Thank you very much, Madam Chair. And for the record, I am Delegate Bonnie Cullison, and I'm here today to present House Bill 21. Thank you for this opportunity. You will notice this year I have a few bills that are related to our different professional boards with the intent of trying to make the boards as effective and efficient in their work as possible. And the residential child care program professionals asked for some changes in their board that will allow them, that they believe will create an environment where they will have the right people at the table and be able to make decisions more efficiently. So I support their requests, and I don't believe there's any opposition. So I'm going to cede my time to the executive director and the president of the board. So Ms. Ham and Ms. Smith, please.
Wonderful. Let's hear first from Darlene Ham. Ms. Ham, I think you might be on mute.
Okay.
There we are.
Yes. Good afternoon, Madam Chair and members of the committee. Thank you for allowing me to testify before you today. My name is Darlene Ham, and I am the Executive Director for the State Board for the Certification of Residential Child Care Program Professionals, known as the board from here on. I am here today in support of House Bill 21. The board currently consists of 12 members, of which 6 are representatives appointed by the secretaries of various state agencies involved in the licensing and monitoring of residential child care programs. The remaining 6 are appointed by the governor with the advice and consent of the Senate of the Maryland General Assembly. This bill seeks to amend the composition of the board's membership by removing one member appointed by the state sub-cabinet, which is the Children's Cabinet. Since being restructured, the Children's Cabinet reassigned the sub-cabinet member position to the Department of Disability. This appointee position is outside of the area of licensing and monitoring of residential children's services and residential child care facilities. There are currently 2 members of the board appointed by the Secretary of Health representing the Developmentally Disability Administration, known as DDA, and the Behavioral Health Administration, BHA, both of which provide licensing and funding of residential services to youth and children in residential child care agencies. These 2 board members from DDA and BHA are very active participants in serving the mission of the board, as well as serving the population of children with disabilities. HB 21 proposed revision will amend the number of board members from 12 to 11, and amending this number will allow the board to achieve success in conducting businesses. The current even number makes it sometimes problematic for the board to vote on certain matters, as well as making it difficult to obtain a majority. Thank you for consideration of this bill, and the board is requesting a favorable report on the bill. Sorry,
thank you so much. No, it's okay. You went over a little bit, but Delegate Cullison ceded her time to you, so you're good. Let's hear back from Nicole Smith, and then we'll open it up to questions.
Good afternoon, Madam Chair and the committee. I appreciate the opportunity to testify before you today. My name is Nicole Smith, and I serve as a secretary for the State Board for the Certification of Residential Child Care Program Professionals. I am also hold a certification as a Residential Child Care Program Administrator, and I am employed as the Executive Director for a nonprofit that delivers residential child care services. And I too am here today in support of House Bill 21. As a member of the board,
I'm going to stop you for a second. Is there something in front of your microphone we're getting a lot of feedback on your audio? Like, no? Try talking again. Maybe it just needed
static.
jostling.
It's like
is this
something
any
is
better?
That is
I
better.
think it was moving my paper. Sorry. Sorry about that. I'll make sure that I take that away. Okay, as a member of the board's licensing and legislative committee, I can attest to the challenge of conducting board business with our that requires a vote due to the current unique makeup of our board. As Ms. Ham said, we have an even amount of board members, 6 appointed by state agencies and 6 appointed by the governor. Decisions related to administrative and legislative action items are often delayed or can't occur at all, which does have a direct impact on the board's ability to oversee the quality of services provided to youth and families who access residential child care. For example, there are some legislative actions that impact health occupation boards on which the board is unable to take a position due to conflict of interest with our 6 state agency members who must abstain from voting. A favorable decision on House Bill 21, amending the board's membership from 12 to 11, would make it easier for the board to achieve majority vote in such situations. The board did consider the alternative of adding an additional board seat to minimize this voting challenge rather than removing the sub-cabinet seat. We talked about adding another seat for a residential child and youth care practitioner, an RCYCP. However, it has been difficult for us to add to fill this seat. Over the past 2 years, we have had that position vacant. And that's because of the nature of an RCYCP's job to deliver direct care services and not have the opportunity within their work to be able to attend board meetings and support board functions. The last RCYCP board member actually did have to resign their seat due to difficulty attending board meetings. So I do thank you for your consideration of this legislation. And for these reasons, the board is requesting a favorable report on House Bill 21.
Thank you so much for your succinct testimony. Raise your hand, members, if you have any questions. And while I'm waiting for hands to go up, I'll just let everybody know those are the only witnesses on this bill and there's no opposition in the file. I don't see any hands raised or any questions. So job well done, Delegate Cullison, and that concludes the bill hearing on House Bill 21. The next bill is Delegate Bandari's bill, House Bill 28, Pharmacists, Aids for the Cessation of Tobacco Product Use. Delegate Bandari.
Thank you, Madam Chair. For the record, I'm Delegate Harry Bandari, presenting House Bill 28. The research shows that smoking is the leading cause of preventable death in the United States and around the world. The finding also shows that most smokers want to quit. With the House Bill 28, Maryland would take a step toward helping them. With this bill, we would save lives. House Bill 28 would grant licensed pharmacists the right to prescribe and dispense nicotine replacement products approved by the U.S. Food and Drug Administration as tobacco cessation aids. Our state law already covers tobacco cessation medication and services offered by licensed healthcare practitioner with Medicaid and the Maryland Children's Health Program. House Bill 28 would simply expand access to those services by extending the same provisions to licensed pharmacists. Though there are over-the-counter options for nicotine replacement therapies available for purchase, financial barriers can prohibit some patients from purchasing these products. A 2-week supply of patches can cost $30 to $45 while a pack of cigarette averages about $7. So if someone has a dollar bill in his or her pocket, which product are they more likely to buy? With a prescription, however, most patients can get nicotine replacement therapies with $0 copay. Lower income people currently have a harder time accessing nicotine replacement therapies. Meanwhile, people in minorities communities face disproportionate health impact from nicotine use. We have research showing that smokers in minority communities are less likely to use counseling and medical support to help to stop smoking. And they are more likely to die from smoking-related complications. Keeping in mind the addictive nature of nicotine, which has been compared to cocaine or heroin, and the stigma attached to addiction, it seems to me that people with tobacco dependence need our help and support. This bill passed unanimously in the Senate Finance Committee, and on the Senate floor in 2020. It was referred to this committee, but did not get a hearing due to the COVID-19 pandemic. Prior to the pandemic, however, feedback from several rounds of hearing was worked into the legislation, authorizing pharmacists to provide tobacco cessation aids is safe, and the CDC has stated that the use of these products is appropriate for most adult smokers. Each year, we spend billions treating individuals for preventable diseases related to smoking. With this bill, we could substantially decrease this tax dollar expenditure and improve the quality of care and health outcome. Currently, 14 states have similar statute or regulation for pharmacists to prescribe and dispense smoking cessation aid. So SB 21 would address a double AIDS inequity and help more Marylanders quit smoking and improve their health habit. Reduced smoking rates would curb the impact of chronic disease such as high blood pressure, diabetes, heart disease, lung disease, and many types of cancer in our state. I would like to request a favorable report on this bill that support our vision for healthier Maryland. Thank you, and I would like to yield the rest of my time to Dr. Galia Santos, and my thanks to those joining us today to testify in support of this bill. Dr. Galia Santos.
Thank you, Delegate Bandari. So let's make sure to add the extra minute. We'll just do it in our heads if it's too hard for Richard to do them back to back. But Dr. Galia Santos, go ahead and you can have 3 minutes. Is Dr. Galia Santos here?
I don't think
If
so.
not, we have a number of other people
Kate,
signed up in support.
Kate would be the next person.
Kate?
Kate
Yes.
is present. She is under the name.
Catherine Berdosky?
Yes.
Yes.
Let's hear from Catherine Berdosky.
Good afternoon, Madam Chair and members of the HGO Committee, and thank you, Delegate Bandari. My name is Catherine Berdowski. I'm a clinical pharmacy specialist in oncology at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins Bayview Medical Center. I'm also a panelist on the National Comprehensive Cancer Network, or NCCN, smoking cessation guidelines, and hold a national certificate in tobacco treatment practice. I give this testimony as a resident and practicing pharmacist in Maryland. I am not representing the view or position of Johns Hopkins Medicine, their cancer center, or NCCN. I am a proponent for having increased access to smoking cessation services and decreasing out-of-pocket costs to preventative care services to populations that are disproportionately impacted, and therefore I strongly support House Bill 28. I practice tobacco treatment in my daily role, and my providers reach out to me to create smoking cessation action plans for our patients. And I penned regularly appropriate prescriptions to our providers to sign to address our patients' evolving tobacco dependence needs. Occasionally, our providers forget to sign and send those penned prescriptions for dispensing, which leads to patient dissatisfaction and loss of critical momentum towards change. Indifference and apathy can dull the urgency of the message that a tobacco-free lifestyle is vital, and this message should be consistent from all healthcare providers. When I tell my patients that there's data to support them quitting now at a diagnosis of lung cancer, that it can help them tolerate their treatment better and make them less likely to have a recurrence of their cancer, they lean in a little closer. What message do we want to send to our patients? This bill has evolved over years with one goal in mind, and that's to create better access to smoking cessation resources for our patients, make them affordable, and make quitting just a little bit easier. This bill addresses pharmacists prescribing nicotine replacement therapy. There are 5 FDA-approved nicotine replacement therapy products: the patch, the gum, the lozenge, the nasal spray, and the inhaler. And most of these are available over the counter and would not require a physical exam for a patient to initiate on their own. Part of the rationale for prescription NRT is the unique opportunity for pharmacists to provide counseling on correct administration. Administration of these products are surprisingly not intuitive and can have up to 15 steps for one administration. Incorrect administration can actually lead to increased side effects, which can deter progress for patients' smoking cessation journeys. Therefore, having pharmacists specially trained in the counseling and education of these products to be a resource for patients is a natural role and responsibility, and I encourage the committee to support HB 28. Thank you.
Thank you, and thank you for being so sensitive to your timer. Let's hear from Kristin Watson. Is she here?
I am.
Perfect.
Awesome. Good afternoon, and thank you for having us today. My name is Kristin Watson. I'm an associate professor at the University of Maryland School of Pharmacy, and I've been a cardiology pharmacist for the past 15 years. I also serve as the chair of the Heart Disease and Stroke Committee that is part of the Maryland's Health and Wellness Council, and I'm an active member of several pharmacy organizations. One of my favorite roles is that I have the privilege of serving our veterans as an ambulatory care pharmacist at the Baltimore VA, and have been able to do so for the past since 2005. And in this role, I am responsible as part of my practice to provide education on smoking cessation and prescribing smoking cessation aids in that practice settings. Pharmacists are well positioned in both the ambulatory care and community pharmacy settings as medication experts through their doctorate degree. The core and trustful professional activities that have been developed through the American Associations of Colleges of Pharmacy state that new graduates at a minimum are able to independently develop a treatment plan with patients, provide education, determine monitoring parameters to assess the safety and efficacy of therapy. And pharmacists also need to be able to implement a care plan, including assisting with behavioral changes through motivational strategies. That is something that is essential for helping our patients to quit smoking. The National Comprehensive Cancer Network, the American College of Cardiology, all recognize pharmacists in their guidelines as essential members of the smoking team. And the recent smoking cessation report from the United States Surgeon General states that pharmacists, in addition to other healthcare providers, can treat nicotine addiction as well as others.
Are you done? Do you need a second to wrap up?
I have one last sentence. Yes, thank you. So our goal is to be able to spread these clinical responsibilities amongst healthcare workers and empower pharmacists to work at the top of their license. And by supporting one another, we can do our best to support the patients that we serve.
Thank you so much for your testimony. Is Meredith Sylvester here?
Yes, I am. Hi, everyone.
Perfect. Go ahead.
Thank you so much. My name is Meredith Sylvester, and I'm a Doctor of Pharmacy candidate 2022 at Shenandoah University School of Pharmacy, testifying as a private citizen. These opinions are my own and do not necessarily reflect the views of the university. As part of my experiential education rotations, I have assessed, treated, and counseled over 80 patients for smoking cessation under the guidance of my pharmacist preceptor. Smoking cessation is not clinically difficult in comparison to other pharmacotherapeutic topics in standard ACP accredited pharmacy schools, such as infectious diseases or oncology or psychiatry. In the eyes of patients, it is a critical challenge that needs ongoing, consistent support. It is logistically and mentally difficult to navigate. Time to nicotine replacement therapy in hand is crucial for patients who gather the motivation to quit. In some instances, there can be days of lag time between when a patient receives counseling to when their prescription is filled. Providers are understandably extremely busy and forget to sign pending prescriptions if they are not the ones seeing the patient. The efficacy of nicotine replacement therapy is directly tied to proper administration technique and repeated counseling. While these products seem intuitive to most, many patients claim that one or more of the products doesn't work for them because of incorrect use. Pharmacists are trained to recognize these fine details. We improve successful quit attempts by troubleshooting adherence or administration challenges and educating patients. Small changes can make a big impact. I had a specific encounter with a patient that had smoked for many years and had multiple quit attempts, but was looking for direction, help, and what to do. I counseled the patient on different options available and came up with a care plan. Prescription requests were sent to the doctor to be signed and covered by the patient's insurance. But as time went on and I had called back for a follow-up, the patient still hadn't received any NRT and was therefore still smoking. One of the pharmacists I was working with at the time then had to reach out to the provider again, asking for new prescriptions to be signed. A one-day process quickly turned into a 2-week cycle, all while the patient continued to smoke. This is a clear example of a patient motivated to quit smoking and would have benefited from a pharmacist prescribing smoking cessation aids. Thank you.
Thank you. I hear that Dr. Elliott Santos is here now. So are you here, Doctor?
Yep, I'm here.
Perfect.
Yes.
So let's hear from you now.
Fantastic. So my name is Dr. Panagis Elliott Santos. I'm a pulmonary and critical care doctor at the Johns Hopkins School of Medicine. These opinions reflect me and not the university or the school. I'm also the director of the tobacco treatment clinic at the Johns Hopkins University School of Medicine. And everything my colleagues have said, what I'm going to add is actually just a real world experience that has been displayed very evidently during the pandemic. In our clinic per se, our patients' smoking consumption and relapse rose over 200%. The pandemic has really impacted many people, and with their mental health consequences, smoking increased, as I said, over 200%. With that said, the amount of providers who are able to care for people who smoke, who see tobacco dependence like any other disease, where quitting isn't the only goal, it's staying quit, preventing relapse, managing them, using pharmacological tools appropriately. The amount of healthcare professionals who are out there who can do that effectively is small, is limited. We need to bring in as many people, as many healthcare professionals to the table to care for these vulnerable populations, or else we're going to just fail them. And the amount of stigma and judgment they face already, and supplement that with limited providers, this patient population in of itself feels already disadvantaged and has medicine's trust broken several times. So I'm all favor for my colleagues in pharmacy to be able to assist with us in the ability to care for these patients effectively and be able to reaffirm medicine as a public trust by having them access as many qualified healthcare professionals as possible to help them manage their tobacco dependence. Thank you.
Thank you so much, Doctor. And we have one more witness to testify in support. That's Blair Innes.
Good afternoon. My name is Blair Innes, and I'm the Senior Staff Attorney at the Legal Resource Center for Public Health Policy, testifying in my individual capacity in support of House Bill 28. Health equity is a long-standing core value of public health, and in fact, one goal listed in the Healthy People 2030 framework is eliminating health disparities, achieving health equity, and attaining health literacy. COVID-19 has shown that we need more action around health equity, and pharmacies and pharmacists have really been part of the solution. The scope of practice of pharmacists has been expanded, and the CDC reported on September 23rd, 2021, that over 70% of current COVID-19 vaccine administration is occurring in pharmacies. But even before the COVID-19 pandemic, pharmacies have committed to leveraging their convenience as far as distance and accessibility, and their trust that they've built within the community to break down access barriers and promote health equity. Pharmacies have increasingly provided enhanced access to a variety of things like routine vaccinations, screening and testing for conditions like HIV and hepatitis C, chronic care management for things like diabetes and cardiovascular disease, support for behavioral health conditions, including mental health and substance use challenges, and the list goes on. Pharmacists have always been ready to do more and are so often overlooked until the country is in the midst of a catastrophe. We saw this in 2009 during the H1N1 outbreak when the pharmacist scope of practice was expanded to administer the vaccine. And of course, most recently, we're seeing it now with the COVID-19 pandemic. And every time they've stepped up and been an integral part of the solution. Lowering the number of tobacco-related deaths in Maryland is no exception. Passing House Bill 28 is a sound public health decision. Thank you.
Do we have questions from the members for the proponents of this bill? I can see a question from Delegate Saab.
Thank you, Madam Chairman. And thank you, Delegate, for putting this bill. I understand. So just so I understand this bill, right now, if you want to get smoke cessation, you have to go to your primary care physician and they have to prescribe it, and then you can go to the pharmacy and buy it. And what this bill will do, you're basically bypassing the primary care physician, and I can go to the pharmacist and say, I'd like you to prescribe for me a nicotine cessation product, and I can just basically pick it up at the counter.
Kate, you want to take that question, or should I answer that?
Take that question. Thank you, Delegate. And thank you for your question. The current process for patients who are interested in smoking cessation counseling is they can either go to the local pharmacy that sells any over-the-counter nicotine replacement therapy product and pick it up on their own, read the instructions, and start the product. Or they can talk to their healthcare provider and see what their healthcare provider recommends. But this is not necessarily bypassing the primary care providers in this instance. It is a mechanism to help decrease the cost of the product and expand the access to the product as well. The products, as Delegate Bandari said, are expensive when they're purchased over the counter by the patient independently. And if that occurs, then the patients are less likely to utilize them because the high cost out of pocket. Did I answer your question completely?
No, not really. So basically, this is one way to bypass or have the insurance pay for it instead of the patient pay out of pocket. So you still have to go to your doctor too. So if you're going to consult with your doctor, why would you need to skip the doctor? One of my fears is I looked at some of the common side effects, and obviously quitting smoking has a lot of side effects by itself by not doing it. So I strongly support people quitting smoking, but some of the symptoms are headaches, nausea, dizziness, feeling anxious, jumpy, irritable, grouchy, angry. It goes on to feeling frustrated, sad, depressed, trouble sleeping, trouble concentrating, increased appetite, weight gain, constipation, cough, dry mouth, and chest tightness. And one of my fears is if we're taking the primary care out of this, the pharmacist is not trained to address some of this because they don't know the history of the patient. If it's a patient that has other underlying condition, they're not looking into that, and it might cause more issues. And I'm just trying to figure out, are we trying to take the doctor out, or are we just trying to get the insurance companies to cover it? And we can still do both without still have the doctor, the primary care, offer the prescription, but have them still make sure that it's an informed decision, and then maybe that's be a different bill or different something for having the insurance companies cover it.
So to hopefully answer your question, this does not completely eliminate the primary care provider. Actually, as part of this bill, the pharmacist would refer the patient back to the primary care provider so that they are clued into any of the decision making and any initiation of new medications that occurs during these counseling visits. A lot of the side effects that you actually read off are confounded by the fact that those side effects are also are also potentially withdrawal symptoms of patients who are trying to quit smoking as well. So as they decrease their nicotine intake, a lot of those symptoms that you described are actually withdrawal symptoms. The bill, I think, really builds in this kind of this concern that you're expressing, because we would be referring patients and encouraging patients to go back to their primary care providers after the interaction with the pharmacist to make sure that they're included in the discussion process. But it's that initiation of the getting nicotine replacement therapy in the patient's hands and to be able to start it, which helps start their smoking cessation journey.
Right, that's what's troubling to me.
Delegate Saab, I appreciate you had your succinct follow-up, and we'll probably discuss this in subcommittee. I think that we have more questions from Delegate Kerr and Delegate Rosenberg.
Okay.
Delegate Kerr?
Thank you, Madam Chair. I read the opposition letter from the Board of Pharmacy, which is listed as unfavorable, but it looks more like it's favorable with amendment. But I also read the letter by MedChi, and similar to what Delegate Saab was asking, but I would like to see if Dr.
Delegate Kerr has frozen.
With his opinion on the issue that Saab raised. Did you miss the last part?
Yeah, I think Delegate Kerr, we missed most of your question. If you could repeat it.
I was just trying to follow up on Delegate Saab's question, but asked Dr. Elliott if he would respond to the issue that Delegate Saab brought up.
Is the doctor still on the call? I'm not sure he's still here.
No, I don't see him. So
may I, Madam Chair, may I respond to that?
Please.
Yeah, in 2020, we have a few doctors on the Senate as well, and it passed unanimously. This question was brought and it was answered. And to Delegate Saab's question, it is accessibility issues, right? The people who has money, they can still buy this medicine over counter, right? And if you don't have money, you have to go through all these things. And if we pass this bill, these vulnerable populations also can get can quit smoking. The people who has money, they already have this. And sometimes when you go to pharmacies, they give the number and you can collect the free medicine. And this is a CDC approved medicine. So yeah, and frankly speaking, it passed unanimously on the Senate.
Thank you. We have questions from Delegate Hill, Delegate Rosenberg, and Delegate Bagnall. Delegate Hill.
Thank you, Madam Chairman, and thank you all for your advocacy on behalf of the smokers. And it looks like this bill is closely patterned on the pharmacists prescribing birth control. But I thought there were a couple of differences and that I want to ask about. So I'll try and ABC it. So it's sort of one question. With birth control, the argument was made by the OBGYNs that prescription birth control ought to be available over the counter. And since that was the argument, that was the basis of saying that pharmacists, being, as you said, medication experts, were adequately qualified to recommend or prescribe prescription items that ought to be. I'm not clear that we're talking about tobacco products or nicotine cessation products that are over the counter or are prescription items because the FDA has deemed them to be prescription items, in which case being medication experts is not the same as being a medicine expert. So I think that's a different category. So if you could clarify that. The other thing is you spoke to the longstanding partnership between pharmacists and physicians, and I guess nurse practitioners, where we do communicate and don't work in isolation. And sometimes when we get recommendations from pharmacists for medications, we may want to bring the patient in and see them or evaluate them. So we might not respond within 24 hours for a recommendation in the example that was given. But you said it's important for the physician to be involved, but you think it should be after the fact. And I'm not clear with the percentage of folks in the US having decreased who are smokers from 21% 15 years ago to 14%. This is not a pandemic moment. It's not the same kind of emergency as other things. And I'm not clear that it comes to the level that we need to bypass the physician input in making recommendations about prescribed medication. So those are the ABC questions, if you could address it. Thank you.
The intention of this bill is Delegate Hill to decrease the annual tax dollar expenditure and improve the quality of care and population health outcomes. Like a lot of minority populations, as you said, that we don't have an emergency. I seriously think that we are still in emergency, because now, like this time, like if you are suffering and you think that you have COVID, and you call the doctor, right? And they said that, no, we're not available and we are going to send you the kits, right? And it comes after 2 weeks. I went through that situation. Like if we pass this bill, and they will have, it's not only accessibility issues, right? As Kate said, right? I mean, we are not bypassing here, but it is costing a lot of, not only money, like so many, being a doctor yourself, you know that this smoking habit is not only costing a lot of money, millions of dollars to our state, but we are losing so many of our constituents. So this is not just the accessibility issues, it is a health emergency issues.
Thank you. And just let me add, Madam Chair, that no disagreement there. But again, the counseling that is so important that pharmacists can still do does not require that they also be able to prescribe. So they can certainly counsel and refer back, make the phone calls to the primary care. Is that not correct? So thank you. I appreciate that. And I appreciate the intention of the bill.
Thank you. Delegate Rosenberg, your question.
Thank you, Madam Chair. If I heard correctly, there are existing instances in the law when we allow for this kind of service being provided, give this authority to the pharmacists. Is that correct? And if it is, what are those instances?
There are no instances in Maryland of relating to nicotine replacement therapy. There are other, what we would say, similarly situated medications, such as birth control, that are allowed to be prescribed by by pharmacists. And there are instances in at least 14 other states where pharmacists do have this authority.
Thank you. That's very helpful.
Delegate Johnson.
Thank you, Madam Chairman. This question is for Kate. It's a two-part question. So if you have money and can afford it, you do not have to get an exam. You can come in and buy these products over the counter. However, if you're lower income, that's the main reason they go get a prescription, because you have to get a prescription for it to be covered by insurance. And some of the side effects that Delegate Saab talked about, are they not lessened or alleviated with the nicotine replacement products?
Yes, they are lessened and alleviated with the nicotine replacement products, because you are the nicotine withdrawal is what brings on some of those some of those symptoms. And by providing purely nicotine through nicotine replacement products, you help to soften some of those symptoms that those patients go through in their withdrawal.
And the first part of that question was, if you have the money, the finances, you can bypass an exam, you can come in and buy the products over the counter. But if you are lower income, is that not one of the main reasons that they get a prescription, so it would be covered under the insurance companies, under their insurance plans?
Yes, if you were not able to afford the products, then if you do have insurance, then that can help alleviate some of that cost burden.
And you must have a prescription for the insurance companies to cover that.
Yes.
Thank you. Thank you, Madam Chair.
Absolutely. I don't see any more hands raised. I'm giving you all a second just in case. Perfect. So no more questions for this panel. Is Sarah Price from the Maryland Chain Drugstores here to testify, or is that just an amendment we have in our file? I don't see her here, so I will just note that there's an amendment from them in the file, and there is an amendment from the pharmacists, as well as the 2 unfavorable letters that were mentioned, but we don't have any oral testimony for those panels. So that will conclude the hearing on House Bill 28. Thank you. And then we'll move right along. House Bill 97, which is Delegate Ampre's bill, work group on Black, Latino, Asian American, Pacific Islander, and other underrepresented behavioral health professionals. Delegate Ampre, please introduce your bill.
Thank you, Madam Chair, and it is a pleasure to be with you all today. Thank you all so much. This bill is in the same position as it was last year, that passed with overwhelming support out of this committee and in the House, which was House Bill 915. And we're bringing this bill back. Unfortunately, last year, the Senate was not able to, time got the best of us, and we weren't able to get the bill out of the committee last year. We're hoping that by getting it in earlier this year, we'll be able to make that happen. So I want to make sure that this presentation as short as possible. Those who are testifying have a limited time to join us. So I would ask that those pieces of information that I'm not able to convey today, you can find in my testimony from last year. And also feel free to look at prior written testimony from all of the overwhelming support that we were able to receive for this piece of legislation last year. The thing that I want to just make sure that we keep in context here before I start through is just to understand that we just got new census data here in Maryland. We are one of the most diverse states in the union. But the unfortunate reality is that in many sectors of our state, we don't have the diversity reflected there. And one of the important sectors that I believe that we have to address right here, right now, is the sector of mental health providers or behavioral health providers. The data shows that there is major gaps in those who people of color who represent in the fields. And the data shows that there is a major connection that providers are able to have patients that they share ethnic and cultural backgrounds to, which leads to more breakthroughs, more opportunities for people to get through whatever they're getting through. And it ties right back into the testimony we just heard earlier around other forms of addiction that we continue to have issues with here in Maryland, here in Baltimore specifically. And also just coming out of a pandemic, all the mental health woes that we're going to continue to see and have, and we're seeing manifesting in our schools, we got to have a more diverse representation of our mental health providers in order to make sure that every resident here in the state of Maryland has an opportunity to get the help that they deserve. Studies show that when physicians share the same race and ethnic backgrounds as the patients, patients report higher levels of trust and satisfaction, and the visits also last longer. And I think that the lack of cultural understanding by healthcare providers may contribute to underdiagnosis or misdiagnosis of mental illness in people from racial, ethnic, diverse populations. Factors that contribute to these kinds of misdiagnoses include language differences between patients and provider, stigma of mental illness among minority groups, and cultural presentation of symptoms. And I think that while the national data is there on ways that we could possibly address this, we need to have something specific to the issues that are preventing us from being more diverse here in Maryland, whether that's looking at analyzing our institutions that provide the actual care, like our hospital networks, and also analyzing our institutions that are actually encouraging people to study and enter the profession with our universities here, right? So every state has their unique issues that we need to make sure that we can study and figure out how we can better address the issues that we have here. With that said, I want to just make sure that we highlight that outside of just diversifying the actual field and having more providers, we're not going to be able to do it overnight, right? We didn't get to this this dilemma overnight. We're not going to fix it overnight. But the important part of also having this commission and having a more diverse group of mental health professionals is also going to allow us to have more people that are able to build more culturally aware practices that can help other individuals that might not share the ethnic and cultural backgrounds, but if they have more training from those who better understand those other backgrounds, because we have a more diverse group of people in the field, it's going to allow for us to remedy some of the issues that we're having with the providers. So with that said, I want to make sure that I have a lot of time for those who are testifying today. I know that we might have had some slips because of the change in time. But again, I want to thank the committee last year for helping me move this bill and make some amendments that were very useful to make sure that we were more inclusive with this piece of legislation. And today I ask you to hear from some of our mental health professionals and read through some of the testimony from community advocates and officials who support this work group and understand the importance of diversifying this profession with urgency. And I really appreciate you all support thus far and urge a favorable report for House Bill 97. Thank you so much.
Thank you very much. Is Dennis Antoine here?
Yes, I am.
Perfect. Let's hear from you next. Thank you.
Thank you so much. Thank you, Chair Pendergrass, Vice Chair Penny Melnick, and members of the committee. I want to thank the bill sponsor as well, Delegate Ampry, for the opportunity to testify on this important issue. My name is Dr. Dennis Antoine. I'm a psychiatrist at Johns Hopkins, and Johns Hopkins is pleased to support House Bill 97. Diversity and inclusion is a core value of Johns Hopkins Medicine, and as an institution, it remains dedicated to reducing health disparities that are present throughout the state of Maryland. Health disparities, unfortunately, have been a long-standing systemic problem in the Black, Hispanic, and Indigenous communities, or the BIPOC communities, persons of color. The COVID-19 pandemic has only exacerbated these disparities due to heightened issues, and other legislation aimed at reducing this blight is very important, as is this legislation. Unfortunately, though, disparities are quite common in mental health. Strategies to improve healthcare would likewise improve mental health disparities, including but not limited to access to care and quality of care. Analogous to healthcare in general, diversifying mental health workforce is an important step to eliminating mental health care disparities as well. Research has shown that disparities in healthcare exist in access and utilization. Efforts to eliminate these disparities have not been always successful in primary care or specialty psychiatric services. Another contributor to the health and healthcare disparities is the lack of a diverse biomedical workforce, as Delegate Ampry spoke to, and that this workforce should reflect the racial and ethnic diversity of communities served by medical establishments. According to the American Association of Medical Colleges, only 2% of practicing psychiatrists in the United States are Black or African American. Beyond medical training, the literature demonstrates that cultural incompetence of healthcare providers and other things such as language differences, patient and provider connection, stigma of mental illness, and cultural presentation of symptoms are some of the many barriers to care that explain these errors in diagnostic processes. As a result, persons of color and other populations have comparable or slightly lower rates in the population. However, those same communities experience a disproportionately high burden of disability from mental disorders. Therefore, in order to deliver high quality, culturally appropriate care, it is critical to act now, in my mind, to increase the diversification of this workforce, but also to give the patients from these communities a better sense of belonging to their healthcare process, all of which would increase the quality of care that would be provided. Overall, Johns Hopkins is pleased to support House Bill 97 and urges a favorable report of this bill. And I thank you again for the opportunity to present today, and happy to answer any questions.
Thank you so much, Dr. Antoine. Let's hear next from Allison Taylor. Is Allison here?
I'm here.
Awesome.
Yeah, sorry, it took a minute to get off mute. Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Allison Taylor. I'm here today on behalf of Kaiser Permanente. Kaiser Permanente provides healthcare and health coverage to over 460,000 Marylanders in the state. We have a strong commitment to reducing health disparities and to hiring a diverse health workforce. I want to come back to a point that Delegate Ampry made that this is a problem that's not going to go that's not going to be resolved overnight, but really needs some planning and some attention on now to make sure that we can get good movement on in the future. So for that reason, I strongly support. Also want to remind the committee that all health carriers in the state are required to meet certain network adequacy standards, including for behavioral health. And so the more providers we can get in the state, the more we can get into our networks and make sure we're serving the members of the state as best as possible. Thanks.
So Allison, next we'll hear from Brian Sims.
Good afternoon. Thank you, Chair Pendergrass and Vice Chair Pena-Melnick and committee members for the opportunity to testify today. I also want to thank you, Delegate Ampry, for sponsoring this piece of legislation. My name is Brian Sims, Director of Quality and Health Improvement at the Maryland Hospital Association. And on behalf of our 60-member hospitals and health systems, we appreciate the opportunity to comment in support of House Bill 97. As a part of our commitment to racial equity, we have been working very closely with our Diversity, Equity, and Inclusion Advisory Group and our Health Equity Task Force on the issues that plague far too many Marylanders, individuals that would benefit from an equity approach. Thus, hospitals are committed to embracing culturally competent care to address disparities in health outcomes and ensure all Marylanders have the same opportunity to maximize their health. However, Maryland is currently experiencing a staggering healthcare workforce crisis, which has been building for years, what many of you are aware of. Long-term solutions will require increasing the pipeline of healthcare professionals, and including Maryland's HBCUs in the work group acknowledges the critical role these institutions play in creating a diverse pipeline of mental health practitioners. By identifying and subsequently addressing the historic barriers of entry in the profession for populations of color, the needs of the entire population will be more adequately met. And finally, healthcare workforce reflective of the communities it serves has been necessary towards combating the coronavirus pandemic in our communities. Similarly, a behavioral health workforce that is more representative of the individuals it serves will be instrumental in gaining trust and combating the stigma against mental health and behavioral health care, particularly in communities of color. And for these reasons, we urge a favorable report on House Bill 97. Thank you.
Thank you very much. And we have one more person who's a proponent of this bill. She is signed up as favorable with amendments, but let's hear from her, Carmen Sáenz, and then we'll go to questions. Carmen?
Thank you, Delegate Kelly and members of the Health and Government Operations Committee. My name is Carmen Sáenz. I'm representing Montgomery County and the Welcome Back Center of Suburban Maryland. While our Welcome Back Center is located in Montgomery County, we have been in operation for more than 15 years, and we have served individuals from Prince George's and Arundel, Baltimore, Frederick, and Howard counties. Center participants come from a diverse ethnic backgrounds, and they are educated in many countries around the globe, but right now they are living and working here in Maryland. We are very concerned, like many have mentioned, about this shortage of linguistically and culturally competent behavioral health professionals providers in Montgomery County, but across the state of Maryland. We consider that this bill is an extraordinary opportunity for us to address this issue. Montgomery County strongly supports this bill, and we ask that you make an amendment to the bill to include the Welcome Back Center as a member in this group. By participating in this group, the Welcome Back Center will be able to offer our expertise. We understand that the work group will identify and study shortages of behavioral health professionals in the state, and the participation of the higher education institution is certainly essential to increase the pipeline of new graduates in this behavioral health field. In addition, it will be essential to include in this effort the participation of the individuals like the center participants who have obtained their degrees abroad and who have gained a lot of valuable experience working with communities that are represented here in the diversity of our state. They are eager to work and return to the health field in behavioral health area, but many of them are still facing many barriers to entering the workforce here in the state. We are certain that we can work together to find solutions and to eliminate or lessen many of these barriers. So I thank you for the time today, and if there is any question, I'll be happy to respond.
Do we have questions from members of the committee? I see Delegate Johnson's hand. Delegate Johnson.
Thank you, Madam Chairman. This question is for Mr. Brian Sims. Mr. Sims, we have had a shortage of mental health providers in the state for quite a while. So in your mind, you mentioned some obstacles. What are some of the obstacles some of the minority community have And, or are they choosing not to go into the mental health field? Or if you could just explain some of the obstacles in your mind that you think are out there.
Sure, Delegate Johnson. I don't want to go into too much detail here, but just some of the historical barriers have been socioeconomic barriers and also just representation in the education field, and folks not seeing themselves there, feel, having the belief that maybe this is not the field for me. And so there's some work to be done on the workforce and the higher education that is inviting and welcoming to a diverse group of persons in that pipeline. But there are, again, some socioeconomic barriers to higher education and the training that is required that has posed a barrier in the past. And then there are some other things that we can definitely follow up with you on offline as well.
All right, thank you. Thank you, Madam Chairman.
Sure.
Absolutely. Next up is Speaker Pro Tem, Delegate Sample Hughes, followed by Delegate Cullison. Delegate Sample Hughes.
Thank you, Madam Chair. And thank you to the bill sponsor for bringing this bill forth. My question is for Allison Taylor from Kaiser Permanente. It was good to hear that you referenced the fact that it's important to have the behavioral health and to address the network adequacy. If this bill were to pass, and or if you could just give me an understanding of how much closer would it be in your portfolio for Kaiser Permanente to get to adequacy in this space?
Thank you very much for the question. It's something that all the health carriers have been working on for a number of years. And I'm very pleased to report that in our 2021 filing, most recently, Kaiser's in full compliance on the behavioral health metric. I'm really proud of that. I think in terms of this, it'll start building a pipeline. So over time, there'll be more and more folks here. So I don't see this as a short-term solution, but the more we can do to encourage any behavioral health providers from entering the market, I think goes a long way towards helping all carriers become in compliance with this.
So any percentage of how close you're getting to your network adequacy for behavioral health, or just curious where you are?
Yeah, so the standard requires a patient to be able to get an appointment within 10 days, behavioral health, non-urgent behavioral health appointment within 10 days of requesting one. And the standard, we're supposed to meet that for 95% of patients. Don't quote me on this, but I think KP is maybe now in the 96 to 97% range. I'd have to check, but we're above that 95% threshold. And I'm really pleased about that.
Okay, thank you. Thank you, Madam Chair.
And Delegate Cullison has the last question.
Thank you, Madam Chair. And this is for the delegate. Delegate, thank you very much for bringing this bill. And I'm sorry if I missed this, if you said it earlier and I missed it. I see a proposed amendment from the Maryland Psychological Association to add them to the work group. Are you open to that recommendation?
Yeah, well, thank you for the question, Delegate. I'm open to it, but at the same time, I think the goal here is to have a work group that can be as thoughtful and I don't want the work group to get too large. That's my worry, right? I think that if it gets too large, I think that we'll end up having a lot of data of what's wrong and not enough focused on solution-oriented work. So I'm open to amending it to add maybe subcommittees where we could have more, groups that could possibly join. But I'm not opposed to it. I'll say that I'm not opposed to it. But I'm wary of the group getting too large to the point where it cannot be as productive as I think it could be.
Yeah, no, I can certainly appreciate that. Just, was wondering if you were aware of their amendment. So thank you. Thank you, Madam Chair.
Absolutely. So I don't see any more questions from the members. And we have no one here to testify in opposition. So with that, I will remind the committee that we passed this bill last year and conclude the hearing on House Bill 97. Thank you so much.
Thank you all.
Fourth of 5 bills coming up is House Bill 112, Delegate Crosby. health occupations, service members, veterans, and military spouses, temporary licensure, certification, registration, and permitting. And we have a number of witnesses here on this bill today. Let's start with Delegate Crosby.
Good afternoon or good evening. Sorry to say that, Madam Chair, Vice Chair, honorable members of the committee. For the record, Delegate Brian Crosby, and it's an honor to present House Bill 112 entitled Health Occupations, Service Members, Veteran Spouses, Temporary Licensure, Certification, and Registration. 2 years ago, the General Assembly unanimously passed HB 349, which provided reciprocity to service members, veterans, and military spouses for professional license overseen by the Department of Labor, so long as an applicant maintained a corresponding license from another state in good standing. In Maryland, as many of you are aware, we're very reliant on the federal government, specifically our 11 military installations. We have over 400,000 veterans, but we also have 29,000 active duty members with 19,000 military spouses. Most of those individuals are on the enlisted pay scale. And as so many of you know, Maryland does have a high cost of living. And so a lot of those families do rely on two incomes, meaning the spouse is also going to work when he or she arrives in Maryland. As I stated earlier, we removed portions of this barrier over the last few sessions through that previous House bill that applied only to the Department of Labor. But as I found out, there are a lot of people that hold or manage licensings in the state of Maryland, specifically the Department of Health. And so what this bill would do, House Bill 112, it would extend the reciprocity to professions overseen by the health department, such as nurses, psychologists, dentists, ophthalmologists, amongst others. These are highly skilled and critical professions for maintaining healthy Marylanders, and we shouldn't prevent their experience or these experienced medical professionals from practicing in our state. Just to go quickly over the requirements, it is not a very loose bill where just anybody can get a license. There are several factors in it. One, you have to have a permanent change of station orders from the DoD for your spouse. Two, you have to provide a marriage certificate. You have to have proof of identity. There has to be a background check. Additionally, there has to be a proof of residency. So not only does your spouse get assigned to one of our 11 installations, you then have to move into the state. And then there has to be a valid out-of-state license that is in good standing. And then the additional and last requirement that we are working on and worked with some of the previous opponents to the bill from last year is that you have to be working towards full licensure. So you have to submit an application for full licensure in the state of Maryland. And that is something that we added to it this year in the hopes that, you know, people should be making a good faith effort to get licensed in our state, but all we're simply trying to do is allow, typically it's women who come into the state with their husband and allow them to join the labor force immediately, so long as they've met the requirements in one of our other 49 states. For these reasons, I asked the committee for a favorable report and hope that we can make the lives of our military families a little bit easier. Thank you so much.
Thank you. Okay, I believe we have Owen Karen here to testify on this bill. Is Owen here?
Yes, ma'am.
Perfect. Go ahead.
I'm Captain Owen Cairn, and I have a unique perspective on healthcare license based on my experience in numerous states, the last being Alaska. I was recently tasked to lead a critical care medical team to Guam with 48 hours notice to assist the island's medical organizations during the pandemic. My entire team, technicians, nurses, doctors, we were all granted temporary licenses within 5 days notification. Also, my wife, who is a civilian nurse practitioner, and I both find it important to give back to the nation as well as the local community that we serve and live in. Getting licensed in a local state while still being nationally board certified has an immediate and direct impact on my ability to increase my experience in military readiness when called upon to deploy to operational areas or support state and local community efforts during this pandemic. My wife was able to work in her chosen profession, which improved her overall well-being, increased her ability to feel an integral part of the local community, and allowed her to provide support for our family. The ability for military spouses to find work during and after a permanent change of station, where military families are moved from one community to another, serves to enhance the military experience, decreases stress, anxiety, and the frustration a move can foster. After arriving at Joint Base Andrews, my wife and I attempted to obtain licenses to work in Maryland, but the process proved detrimentally slow and time-consuming, which for a family in need of dual incomes does not portend to a positive experience. The Maryland process, beginning from end, took us 8 months, numerous phone calls of being on hold for up to 6 hours, being disconnected, and over 2 visits to the Board of Nursing office. However, my wife was able to get licensed in a neighboring state, more timely process, 14 days to be exact. Thank you for this opportunity to provide my testimony.
Thank you very much, and thank you for your service. Tyler Schaff.
Hi, good evening, Madam Chair, Vice Chair, and members of the committee. I'm Colonel Tyler Schaff, Commander of the 316th Wing and the Installation Commander here at Joint Base Andrews. We welcome the opportunity for our military members, our veterans, and military spouse healthcare professionals to obtain expedited licenses for them to provide healthcare support at state and local community healthcare facilities. The state's recent membership in several healthcare-related compacts opens the door for more license portability. But we recognize that our military members and their spouses may have valid licenses in states that are not part of the compact. Therefore, this bill's improvements for the state's health boards to provide expedited licenses creates a win-win scenario. First, our military healthcare professionals will be able to work in a greater variety of healthcare areas that will help increase their experience and improve military readiness. To ensure they maintain their medical skills needed to support our nation's critical wartime and humanitarian functions while deployed, we rely on our civilian partnerships and community-based healthcare organizations. However, Maryland law requires our military healthcare professionals to have Maryland licenses that currently cost a full medical team approximately $50,000 in biannual license fees and over 1,000 man hours, leading to delays of 3 to 12 months. Second, our military spouses and veterans will have greater opportunities to work in their chosen healthcare careers, which leads to spousal support to their families, improved overall well-being, and become a more integral part of the local community. Lastly, the addition of qualified and licensed military-oriented healthcare professionals in the state of Maryland will help provide state and local community healthcare facilities with increased flexibility to mitigate potential or existing staffing shortages. This bill will also help improve Maryland's low rating within the annual Air Force assessment to support our military families regarding license portability. Thank you for the opportunity for Joint Base Andrews to provide testimony for this very important and positive bill.
Thank you. Thank you so much. Let's hear from Erin Dorian.
Thank you, Madam Chair, members of the committee. My name is Erin Dorian. I'm the Director of Government Affairs and Policy for the Maryland Hospital Association. We appreciate the opportunity to comment on House Bill 112, and I want to just say that last session we provided written testimony in support of the bill, but this session we felt that we really needed to come in and provide oral testimony, just because I think we all have seen the toll that COVID has taken on our healthcare workforce. We are really in probably the worst healthcare workforce crisis of a decade at least. Our latest estimates show that there are approximately 3,900 nursing vacancies in Maryland's hospitals. Executives from Maryland's hospitals have been discussing short and long-term strategies to recruit and retain healthcare workers in acute care and throughout the healthcare system. These include ensuring every available trained healthcare worker in Maryland can serve Maryland residents. One strategy is a Green to Blue initiative, which creates opportunities for retired or near retired military veterans and their spouses who qualify to quickly obtain a Maryland professional license. This solution is in line with HB 112. Streamlining the licensing process for qualified health professionals living in Maryland leverages their experiences and will improve access to care. Long-term, we must build the pipeline of healthcare professionals to resolve our healthcare workforce crisis, and breaking down historic barriers for certain populations to enter the profession is necessary to meet the care needs of the entire population. For that, we humbly submit our testimony and would hope that the committee submits a favorable report on House Bill 112.
So much. Let's hear next from Christopher Arnold.
Good evening, Madam Chair. From the runway at Reagan National, the Department of Defense is grateful for the opportunity to support the policies reflected in House Bill 112. I'm Christopher Arnold, Northeast Region Liaison at the United States Department of Defense State Liaison Office, operating under the direction of the Undersecretary of Defense for Personnel and Readiness. As brevity as the soul of wit, I will endeavor not to repeat much of what my written testimony has already said about the department's plan, the status of license portability in Maryland, and the federal statute, which includes licensure as part of the military services strategic basing criteria. Pre-pandemic research showed unemployment rates for licensed military spouses ranged as high as 28%, and the department has established and is working on 3 lines of effort to improve license portability for military spouses. These lines of effort seek to improve state licensing laws to allow a military spouse to receive a license with minimal initial paperwork within 30 days of an application, to ensure state licensing boards implement their laws and make information about their application practices accessible to military spouses, and to approve profession-specific licensure compacts, which the department perceives as the optimum long-term solution to portability, an area where Maryland and this committee has unquestionably become the leader nationwide. It has been a great pleasure for me to get to know the majority of you this past year, and as you are aware, this legislation expresses the department's fullest intent on one of our key issues that is so important. It is now the 4th line of effort in our national defense strategy, and the First Lady has called a national security imperative. As there is not currently a compact for every occupation, nor is every state a member of each compact, the department continues to engage the states on the issue of military spouse licensure and pursue a variety of approaches to reciprocity simultaneously. The best evidence we have about the quality benefits of licensure relate to occupations that are universally licensed, which tend to have more harmonized standards across states. Where we do not have any strong evidence is to suggest that the type of licensure recognition in this bill is associated with worse quality or worse care outcomes. We are particularly grateful to you, the chair, Madam Delegate Pendergrass, I should say, and Delegate Kelly as well, the bill sponsor, Delegate Crosby, your amazing staff, the incredible HGO committee staff, Sharon Ringley, Lisa Simpson, for all of your efforts on this legislation over the past year. And on behalf of DOD, we thank you for your consideration of the policies expressed in this bill.
Thank you very much. Do we have questions for the panel of proponents from the committee? I'll give you a second to raise your hands. Looks like we have a question from Chairman Pendergrass.
Thank you, Madam Chair. I appreciate that. It's important for me to say something at this point, and that is that it is totally shameful that the Department of Health is in such bad leadership that we see nurses standing around the block trying to renew their licenses out in the cold. We can't solve problems of bad service, bad running of the department by easing our requirements for competent workforce. It may be that the people who are military or military spouses are very competent. Some of them may be able to get licenses through the compacts that we have. I was pleased that Colonel Schaaf mentioned that and is aware of that. We don't have compacts with every state in the union because we are not sure that every state in the union has the same stringent criteria that we do, which is not to say anything against the qualifications of the military, but at the same time, it's to say we have qualifications that we expect people to meet, and that's why we pick and choose the compacts that we're in, to be in them with other states that have similar requirements. So our job here is, one, to try to get the department to do a much better job speeding up a process that is abysmally messed up, and second, to ensure that the people that are serving in a health capacity, the citizens of Maryland are qualified and that our citizens are getting safe treatment. These two things need not be mutually exclusive, but at the moment we're having problems. So I'm sorry that we can't solve the problem of the mess that the health department is in by passing a bill that we're not sure is good. We will look at it very carefully. And I appreciate having been a spouse of a non-military, non-DOD husband, and then a DOD husband, and been moved across the country and across the state. And I understand about getting licenses easily in the state of Maryland. And it is a problem. I don't deny that. We'd like to get the workforce up to speed, but again, it's the department that is failing. If you want to work with the governor's office, and I heard you talk about the first lady, maybe you could get them to make the department that they are responsible for do their job, give them the staffing that they need to be able to do their job, and give them the computers that they need to do their job. And I apologize for making a statement instead of a question, but I think it's important to set the stage before the subcommittee deliberates on this bill, that we understand the pressures that there are. We appreciate your service. I appreciate my husband's service, my father's service, and my father-in-law's service, and my grandfather's service to this country. You're very important to us. That said, we have to do the job that we are elected to do, which is make sure people who are serving the people, delivering healthcare, meet the standards in this state. Thank you.
Thank you. It looks like we have one more question from Delegate Krebs, and then we have a favorable with amendment panel and an opposition panel. Delegate Krebs.
Thank you, Madam Chair. This is a problem that we've been having for many, many years, and I thought we had dealt with it when the former Lieutenant Governor had an actual task force about this, and I thought we had solved some of these issues. But one of the questions, I'm not sure who can answer this, but I have been told many, many times that the Secretary of Health has no authority over boards. And I've told that many, many, many times. That's why we go directly to them. So I'm basically asking someone on committee or whatever, because I'm literally working on a bill for that, because I've been told there is no authority from the secretary that the legislature has given them to do what you're asking them to do. And maybe, I'm not sure if you can answer the question, but I'd like, it's a big question.
So is there someone you were directing the question to?
Delegate Crosby knows the answer to that, or maybe, I don't know if the Board of Physicians, when they come up, have the answer to that, but that's been my impression, and that's something that I think needs to be fixed, so that the secretary does have authority over the board, a little bit over the boards. Right now, I've been told there is no authority over the boards.
Delegate Krebs, I honestly don't know that answer, and I don't know.
I think it's an important question.
We can raise it again when the Board of Physicians comes up. Thank you. I don't see any further questions for this panel, so let's move on to the favorable with amendments. That will be Robin, Elliott, and Lynn Nash. Robin.
Good evening, Robin Elliott. I'm here today on behalf of the Maryland Nurses Association, the Licensed Clinical Professional Counselors of Maryland, and the Maryland Occupational Therapy Association. And just thinking about the history of this, it was about 9 years ago that the Maryland General Assembly did pass a bill that requires all the boards in the state, including the health boards, to do expedited licensure. And in some cases, it's worked. I spoke with the Board of Occupational Therapy to get more background information. They're able to usually process a license administratively within a week, and then take it to the board at the next board meeting, and they meet monthly. So in some cases it works. I think Delegate Crosby is right to raise the question of temporary licenses. A number of boards have them, like the Board of Nursing can waive a license or can do a temporary license if someone is waiting for their criminal history records check. I'll just flag that generally we think permanent licensure is probably better. It actually saves on the paperwork. Someone just has to apply one time. And then for those providers who bill, insurance companies require permanent licensure for credentialing. We are a little concerned about the waiving of core competency requirements. For example, professional counselors in other states may not have the scope to diagnose, which means they may not have the same educational requirements. We think there are different pathways to get there, and we are very happy to work with Delegate Crosby and the committee. Thank you.
Thank you very much. Lynn Nash.
Thank you very much. I appreciate the opportunity to speak with you this evening. My name is Captain Lynn Nash. I'm the Communications Director for the Maryland Military Coalition, and I served 30 years in the Army and the United States Public Health Service. I retired in 2017. I'm also a volunteer with the Medical Reserve Corps. Maryland Responds here in Maryland, and I have personally administered over 15,000 COVID vaccinations. While I have a valid Vermont nursing license, I'm only able to vaccinate right now because Governor Hogan has an emergency powers declaration in place. So currently, Maryland regulates 20 occupational categories. This bill allows for health occupation boards to issue a full or temporary expedited license. But I think the key piece, Madam Chairwoman, is that this is for people if they meet all of the requirements for licensure. So when I was a federal nurse, my Vermont license was recognized. If I were to practice or serve on a nursing faculty here in Maryland, where there is a significant shortage, and that shortage existed before the pandemic, I would have to go through the onerous and frankly expensive process of getting licensed in Maryland. I would still have to maintain my Vermont license, $190 a year, but I would have to go again. But I do have two asks. First, this is highlighting military members, and we have a huge number of NOAA and public health people here in Maryland. I know I represent 1,200 of them. And in addition, you're talking about veterans within 1 year of service. I ask you to reconsider that. The coalition strongly supports and asks for a favorable report on this bill. Thank you, Delegate Crosby, for advancing it.
Thank you very much. Do we have questions for the favorable with amendment panel from any members? Delegate Hill.
Thank you very much, Madam Chair, and thank you all for testifying. This question is for, I'm losing it on the screen, the woman who just testified.
Nash.
Thank you, Captain Nash. I'm sorry that I wasn't able to do that. Since you're experiencing, do you feel that if we were to move forward, that the requirements should not simply be that that the person transferring in have an active license, but that they should have been in clinical practice for a year? I mean, actually not at home with a license that they keep valid because they pay every 2 to 3 years and get some CMEs or whatever, but that they should also have been in practice for some period of time before?
Absolutely. And most states have a requirement for ongoing competency and currency. That means education and training. And certainly I'm nationally credentialed and, take that number and double it or triple it for my certifications. So absolutely. But one of the pieces about that is, it's, as already described, it's an onerous process, like 12 months. It can take up to 12 months. And I'm here to tell you, I had a top secret clearance with compartments, but a background can still take weeks to months. And I lived overseas, so that makes things even a little more difficult. But yes, I would want a currency and competency piece to all of this legislation. It doesn't necessarily have to be paid, however. So many of us are really interested in volunteering our time. So there would have to be a method of being able to address that. But thank you for the question.
Thank you.
Thank you. I see no further questions for this panel. So let's move on. Thank you for your testimony. Let's move on to the unfavorable panel. Matthew Dudzik.
Good afternoon, Madam Chair, members of the committee. I'm Matthew Dudzik with the Maryland Board of Physicians.
I want to begin by saying that, while the Board of Physicians is submitting is recommending an unfavorable position on this bill, we specifically have issues with the temporary licensure components. The Board of Physicians is strongly committed to reducing and eliminating barriers to licensure. We know exactly how essential it is to Maryland's healthcare workforce to ensure that qualified individuals can begin practicing as quickly as possible. And this is doubly true for our service members and their spouses. Our main concern with the temporary license is that every time we have explored this idea, we came to the conclusion that doing so would not materially decrease the amount of time it takes to become licensed. We pride ourselves on issuing licenses as quickly as possible. The vast majority of our licenses are issued within 10 days of receipt of the fully completed application. And that's for all licensees. Service members and their spouses actually have an expedited process on top of that. We have also been working hard to create multiple alternative pathways to licensure. Dr. Olzik from the board is here as well, and I believe he will speak to some military-specific regulations that we've been working on. But we've also been developing reciprocity agreements with the medical boards in DC and Virginia. We are strong members of the Interstate Medical Licensure Compact. And we've been working on developing a licensure by endorsement process that would remove many of the credentialing steps for qualified applicants. Again, the board strongly supports the intent behind House Bill 112. We believe that we are already meeting many of the requirements that were set out within it. And we feel that temporary licensure is the incorrect approach in this case. Thank you.
Thank you. And finally, let's hear from Dr. Mark Olzik.
Yeah, thank you, Dr. Olzik. I'm the vice chair of the Maryland Board of Physicians. I'm also a veteran, 13 years in the Navy, practiced in 6 states and 3 overseas countries with the Marine Corps, and then also worked in the VA. I'll echo Matt's sentiment. We don't want to create, we're all for expediting licensure, but we don't want to create an extra category of licensure or complicate the process by which we assure quality for our physicians. It's important to know that if you work in a federal institution, whether it's VA or DOD, all you need is any active license, good in any state. So when I went from California to Wisconsin, I could keep my California license. I didn't have to get a new license in that state. Any state license or District of Columbia is good to practice in any military or federal facility. So that removes some of the burden for time. I also, transferred around the country. I experienced no personal problems getting licensure. You usually know well in advance of your change of duty station, and while moving is never an easy thing, the licensure was not the most complicated part. As Matt noted, we have for the physicians reduced and waived fees. You can use military training to qualify for the education credits. Service years as a general medical officer can be substituted for the GME. We waive continuing medical education requirements, CME. And of course, there are the other interstate agreements, the compacts, and everything else. So I think there's plenty of avenues where we can expedite licensure and make it a lot easier, but we don't want to compromise on our quality checks at all. Thank you.
Thank you very much for your testimony. We have a question from Delegate Morgan.
Thank you, Madam Chair. My question is either one of the opposition from the board. How many people are we actually talking about here? Does this situation come up a lot?
Sorry about that. Thank you. Thank you, Delegate Morgan. It does not come up very frequently. It's I don't have exact figures, but we have a it's an automatic process, so we don't always see it every time a military service member requests an expedited application. There's actually a checkbox on the application that you can request. And when you do so, it automatically flags the application so that it goes to the top of the list, receives first priority when our licensure analysts are processing it. So it's thus far been a very smooth process. And actually we have been in communication with a number of the stakeholders, including many of the folks that testified today. We have offered on several occasions to, review any areas where there have been, undue delays. And we have, at this point, not been provided with any cases where there has been a delay for the Board of Physicians specifically.
But I guess what one of the questions the bill sponsor said that caught my ear, it wasn't just the military people themselves, it was also their spouses. So their spouses wouldn't have that expedited treatment, correct? If they were licensed in another state?
That's actually incorrect. The Veterans Employment Act of 2013 is what we based our expedited licensure process off of, and that covers both military members and their spouses.
Okay, I appreciate you answering the question. Thank you, Madam Chair.
Absolutely. Delegate Bagnall.
Thank you, Madam Chair. And I just had a follow on to Delegate Morgan's question, because you mentioned that you don't always know it's a expedited process. They click a box. So do you have any information on what that looks like, what the timeline is, and or where there have been complications or extended time frame, or is that based is that a complaint based process?
Thank you, Delegate Bagnall. It is primarily, we tend to hear more when things are not working properly than when things are working properly. I have seen how the expedited licensure process works from an internal point of view, but to my knowledge, we've not received any complaints of delays in licensure coming from specifically from military members or military spouses. And again, as I mentioned to Delegate Morgan, we did specifically ask some of the stakeholders on this bill if there were any cases that they were able to identify, so that if there are deficiencies, we of course would like to correct them, and that offer still remains.
Thank you, Madam Chair.
I don't see any further questions. Let me just double check. Okay, so that concludes the hearing on House Bill 112. Thank you so much. And last bill of the day, and our favorite because it only has one person testifying in addition to the sponsor, Delegate Sample Hughes's bill, House Bill 155, State Board of Examiners for Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists. Revisions. Delegate Sample Hughes.
Thank you, Madam Chair, and good evening to everyone. Thank you to our Chair Pendergrass and our Vice Chair for leading this committee. I'm here today to ask for your support for House Bill 155, which is the State Board of Examiners for Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists. What you'll see is that over the years, and many of this committee members know that I've been working closely with this particular board. And so today, this bill in particular is to better accommodate our new members to the board, those being the music therapists and the audiologist assistants. We were able to add them on last year. Again, thank you to the committee for seeing that through. So this bill, it updates the board statute to include music therapists and audiologist assistants. The second part of it is that the bill will change the language of the quorum requirements, removing the need for the presence of an audiology assistant. The board felt this requirement was unnecessary as audiologist assistants are now overseen by audiologists. And finally, the bill would clarify the reciprocity guidelines for licensure. This is to ensure Maryland is able to attract quality candidates from other states and do so in a timely fashion. I will also share with the committee that one in particular, the music therapists have been appointed to the board and have attended at least 2 meetings already, and is providing due diligence in their efforts for providing good information and helping change some of the regulations. So what we put forth is working, and it's providing the state of Maryland persons who are interested in this area to House Bill 155. And thank you for your time. And I do have one witness.
Wonderful. Thank you so much. Caroline Stein.
Good evening. I'm Carolyn Stein. I am the board chair of the Board of Examiners for Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists. I am a practicing speech therapist and have been doing so for 15, 20 years now. Thank you so much for allowing me to testify. You're supportive of this bill. Delegate Sample Hughes, thank you so much for your introduction. It was pretty much a longer version of what I was going to say. Basically, what we're trying to do here is to create better access for services and add some regulations for the music therapists. We've just recently added music therapists onto our list of professionals that we license. The first thing that we did is we changed the quorum requirements so that we could add music therapists to our quorum. We don't include audiology assistants or SLPA assistants, speech therapy assistants, because they're already represented by those professionals that supervise them. The second thing is, and we've talked a lot this evening about reciprocity. What we're planning to do here with reciprocity is that we're going to have a service provider who's coming into the state of Maryland, if they can complete an application for a license and be granted preliminary approval, we can allow them a license with that information. Thirdly, we're also licensing audiology assistants and developing a scope of practice there. And this will provide more access to audiology services. And then again, we're going to establish a music therapy committee of the board to allow them more room to talk about, their needs in the state. And that's basically a quick summary. Thank you so much for allowing me to testify.
I am looking for questions from the members. I don't see any hands raised, which is the sign of a good bill that makes sense to people. So thank you so much for your testimony. There is nobody signed up in opposition to this bill and no questions. So that concludes the hearing on House Bill 155. And for everybody who was here today testifying and presenting to us, we really thank you for both your presentations and the valuable work that you do in the community. And with that, the HGO meeting today is adjourned.